Hello everyone and welcome. Let me know if you can hear me okay. Hello, hello. Party time. I don't know about that. The after lunchtime when everyone's digesting, I'm probably gonna fall asleep, but that's okay. Alright. So happy you guys are here to join me. May not be able to tell by my face or my vocal inflections, but I'm quite excited to be. Hello, hello. How excited you guys seem today. That's yes. Well, I figured leaving off on laxatives, the last time we met was probably, kind of constipating your mind to some degree. And so I figured this would be a good topic to kind of flesh out all that information and help you learn the stuff a little better. So it seemed like a good stopping point. I will attempt to keep the potty humor down to a minimum, but we'll see how that goes. It could be difficult. And I'm glad you guys are all doing your that substance use disorder education stuff. I like 2/3 of the class in. That's fantastic. Most of you guys got done the first couple days, so I really appreciate that. Very smart of you to get it done early before things started kind of ramping up. Good. I'm glad. I hope all of you found it, enlightening. Kind of give you some ideas about really the scope of the issues that we're dealing with in healthcare. And again, you'll find it um, really affects all aspects. Even like working in pediatrics, you can run into this stuff. We'd have kids, for instance, of like sickle cell disease, and they have really chronic pain issues, and you'd have issues to where kids are coming in, their pain is like completely uncontrolled, and you're like, well, like why in the heck are the medications not working? It's because the parents are actually stealing them, and either using them themselves or selling them for money to, maybe pay for other things, whatever drug they were happen to be into. So sad state of affairs, but it is good for you guys to have some context and know how to help manage these people because you're going to be running into it pretty frequently. I actually had an acquaintance of a family member actually had to undergo open heart surgery recently, and it was actually really interesting how in their history they had substance abuse issues, and so I imagine dealing with that would be quite difficult because undergoing something as invasive as open heart surgery and then trying to manage their pain afterwards with someone who's a recovering is recovered with their addiction, can be really challenging. And we'll get into a lot of pain management stuff in the ortho section coming up in just probably a couple weeks or so. So we'll get to talk more about that and hopefully be able to touch on a lot of the stuff that you guys covered in that substance use disorder education. So, but anyway, we'll get started here in a minute. If you have questions, feel free to post them up again on the sticky board or in the chat. That's totally fine. And it's 12:30, so I'm gonna get started. Start my recording here. So I did have one question up on the board. It was probably kind of a late submission, so I want to go ahead and touch on this real quick. Jackson saying, I have a MVA patient with a mid-shaft femur fracture, refused opiates because of his history and concern of relapse. Yeah, you'll find kind of people on both ends of the spectrum there where you have, certainly those people that will come in and they say, oh, I'm allergic to everything except for that Dilaudid. That's the only thing that works for me, which have kind of those obvious like pain-seeking behaviors, that a lot of people may kind of stereotype with people with substance use disorders. And then you have the complete opposite where people, even if they don't have a history of anything, they're really concerned about the addictive properties of the drugs and they may just outright refuse them, and sometimes like NSAIDs just aren't going to be enough to really cover what they're experiencing. So, it can be a challenge on both sides of the fence, unfortunately. But anyway, so someone had a question from our talk of cannabis from last time, and they had a question about cannabis hyperemesis syndrome. And so someone's asking, is that likely a rebound phenomenon because we talk about using cannabis to help reduce nausea and vomiting? And interestingly enough, it's not really a rebound phenomenon because we'll see that the treatment for cannabis hyperemesis syndrome is actually cessation of cannabis use. So what you're going to find is that in maybe lower doses, especially with drugs like, dronabinol and nabilone, like those are going to be very pure, just basically just THC alone. Taken at appropriate doses, they have their antiemetic effects, and so they can be pretty effective for that, or just the actual cannabis itself, however they choose to ingest that or absorb it. They're going to have that nausea, vomiting, kind of relieving sort of effects. But it's with people who have really heavy chronic use. Those are the people more likely to run into the hyperemesis syndrome. So it almost seems to be more like a toxicity from having too much of it around. And again, we know very little about cannabis in general because, again, research has been difficult to perform. So it'll be interesting to see in the future if we're able to find out kind of more of like the pathogenesis of this. But just remember that if you have someone who you suspect has this, and again, they have that history of like taking a lot of hot showers because that helps relieve it, cessation from marijuana is really the fix, so they tend to find that will then be eliminated just on its own by not smoking anymore or whatever they use. Someone saying Helidac first-line treatment for H. pylori PUD compared to the 3 and 4 drug regimens listed. Well, the Helidac, if I go back to that real quick, where's that listed at? I listed it somewhere. Sorry, I'm trying to find this here. Yeah, so this one here, not necessarily, right? Remember, when you're going from a 3 to a 4 drug regimen, that you want to add on the bismuth. That's really the big difference, So for like a typical 3 drug regimen, you'd probably go with 2 antibiotics, and then add on something like most likely a PPI nowadays, but you could use an H2 blocker as well. So I would know that I would necessarily use that first line necessary. Could have some people probably used it, perhaps. If they are, I think you just get faster healing if you have some kind of acid suppressive therapy on board as well. So that's probably what I would say to that. Unless you guys have seen something different, we can dive more into that. Okay, so let's see. No more questions so far. So we talked about antiemetic drugs, so kind of preventing things from coming out of the top end. Now let's talk about how we can try to get things moving out of the bottom end here. And so this is something you're going to be running into quite frequently. As I mentioned, like in pediatrics, we see this all the time. Kids complaining of abdominal pain frequently. Quite often it's going to be due to constipation. You take the KUB and you just see all those nice stools that are just kind of just hanging out there, and it could be due to a lot of different things. We'll get into some of the reasons for that. But, if you think about if you work in surgery at all, like you're going to oftentimes require patients to have like a bowel clean out, in order to, especially if you're working like GI or something like that. So a lot of different specialties you might run into these medications here. And we have a lot of causes for it. So certainly things like IBS, and you can have issues of like heart failure and things like this. I tend to run into problems with like hypercalcemia frequently, especially if they're taking medications that contain calcium, like calcium carbonate, as we mentioned before. Oh my goodness, I'm so sorry. I am totally an amateur at this still, so thank you, Selena, for mentioning that. So anyway, so common causes here. As I mentioned, the hypercalcemia can be an issue, especially if you're dealing with things that like are blocking calcium influx too. Like we talked about calcium channel blockers frequently causing constipation here. Certainly lifestyle issues, psychogenic causes, especially like kids, they'll have behavioral issues to where they had a painful experience trying to poop, and then they don't want to have that pain again, and so they'll just sit there and hold on to it. So a lot of psychosocial stuff that may go into this as well. Now, drugs, this is a very, very common thing here, and I'll share an anecdote with you of a family member who had run into this problem as well. But basically, drug-induced causes, opioids are a huge, huge cause of this. You have patients with chronic pain management. If they're on opioids, chances are they're going to need some kind of maintenance therapy to help make sure that they can pass stools, because this will cause a pretty significant decrease in peristalsis just due to the opioid receptors you have sitting on the GI tract. We'll talk more about that a little bit later in the ortho section. Anticholinergics, we know we're going to be doing this as well. So like your Benadryls and really anything that has an anti-muscarinic property is going to slow down the GI tract. Now, some other things you may not necessarily think about would be things like antacids and iron products. They tend to have constipating effects as well. And again, you can imagine how patients might have multiples of these medications on their profile, all kind of having some synergy there. And we mentioned calcium channel blockers being pretty notorious for causing constipation as well. So but just to give you an example, we had we had a family member who was, because me and my wife are both pharmacists, so we oftentimes will get questions about, oh, well, what medication should I take for this? What do you think about this drug, X, Y, and Z? And so the person had basically said, yeah, I'm having these stomach cramps. What kind of medications can we use for that cramping? Initially you think like, okay, well, maybe like an antispasmodic, like the hyoscyamine that we talked about last time when we were talking about antiemetics and drugs like that. And but we started to dig a little bit deeper, and we're just like, okay, well, how often are you stooling? And they were like, oh, well, I haven't gone since like last week. And we're like, wait a second. Let's dig into this a little bit further. So then we started to get some questions about like, well, what kind of medications are you taking? Turns out they're on chronic opioids. Turns out they have a calcium channel blocker as a antihypertensive. And so the thing was is the stomach cramps are due to the fact that they're full of stool. We need to get those stools gone as opposed to giving something to treat just the symptom that they're experiencing there. So someone says, Matt was asking, why does calcium cause constipation? I need a refresher on the pathophys. Thanks. So recall when you're dealing with smooth muscle that calcium influx is going to have a big effect on how that muscle is going to be contracting or relaxing. And so remember, smooth muscle is like really good at staying contracted or relaxed for like a really long period of time, as opposed to like your skeletal muscle, which is made for more kind of quick action. So you tend to find either if you have way too much calcium causing that muscle to sort of be in a constant state of contraction, or maybe if you're even blocking it and can't get the muscle to contract in the first place and you're inhibiting it, that can keep the muscle from functioning normally, right? So that's why you can either see it seems sounds counterintuitive that a calcium channel blocker and hypercalcemia could both cause constipation, but both are disrupting the act of peristalsis in their own way by affecting how the calcium homeostasis in that smooth muscle. So hopefully that makes a sense. If not, we can maybe dig out some physiology slides or something from a couple of years ago when I taught that. But yeah, let me know if that didn't clear things up. Regardless of, so going back to that family member, we were just like, wait a second, okay, so they wanted medications to treat a side effect of the other medications that they were on. And so, that's one of those things where you have to really dig down and get a good history, which is what you guys are going to be experts at, and trying to figure out, okay, what's really going on here? Be a detective and get, okay, this is the medication's causing the problem. I don't want to necessarily add on more medications just to fix that, So we'll talk about some other strategies here in just a little bit. Obviously, for these patients, try to relieve their symptoms, especially if they're having kind of acute issues. Try to reestablish kind of normal bowel habits for them and obviously quality of life. Again, you will find that nothing can really help out a patient's quality of life better than a good bowel movement. My wife, she did her second year residency, pharmacy residency in pain management at the Veterans Affairs hospital up in Gainesville. And it was interesting because a lot of those patients, especially they have like, end stage cancer and things like that, could be quite painful. They're on all these opioids and everything. And so she would go in and talk to these patients and say, okay, well, what's your pain scale right now? And, they say, oh, I'm like an 8 out of 10. They're in a lot of pain. They're just so uncomfortable. And even some patients were not really like verbal, but you could just tell based off of like their body language. You could tell from their vital signs, they were just super uncomfortable. And, you're saying, okay, 8 out of 10 pain, let's go and add on more pain medications, right? But that wouldn't fix it necessarily. It could make things worse. Then they figured out, wait a second, let's get a good bowel regimen on board, help these patients have good normal bowel movements. And all of a sudden you come back, pain's like a 4 out of 10, So again, these are important things, even though it may sound a little silly to talk about. But, again, you'll find that a lot of patients will require these. So a couple different mechanisms we can go with in terms of laxatives. So we can try to increase motility directly, right? So we have things like metoclopramide and erythromycin that we talked about before. We can do things like trying to increase the water content of the stool. As frequently you'll find these patients may have really like hard, kind of desiccated stools that are difficult to pass. And so we'll have some drugs that can help out with that, and help out with like the lubrication and increase water content to make them more easily passable. And then another big thing we can do as well is try to decrease colonic water absorption. If you recall, the colon is really important for helping with water reabsorption and helping keeping the water balance appropriate in the large colon there. And so if you block that, if you try to get more water and salt into the GI tract, that's going to cause this hyperosmolar effect. It's going to cause some stretch, and that's going to lead to the patient have that urge to defecate, more from like a neuro sort of standpoint. So we'll talk about some ways we can do that. And again, where we're going to be using these, I mentioned a few already, things like trying to prepare bowel for surgery. So if you need to clean out the patient from that standpoint, if they need like a colonoscopy or something like that, potentially that could be one reason. If you have, sometimes we can hasten the excretions of toxins. This is not something I do too frequently, but for some things that are kind of hanging out in the GI tract, like for instance, lithium, we'll talk about when we get into the behavioral health sections, medication use for bipolar disorder. If someone overdoses and has a ton of lithium in their belly, I can actually use some of these laxatives to try to move things through to prevent them from being absorbed. We call that whole bowel irrigation. So don't get too much into detail here because it's kind of outside of our scope a bit. But, post-operative, especially if patients received a whole lot of opioids during surgery, or if they need it for post-operative pain management, you want to have patients make sure they're stooling then as well, because you don't want to have like a post-op ileus or something like that develop. For some patients, you don't want them to strain too much, right? Especially from like a cardiovascular standpoint. So having them have an easier time stooling, requiring less effort, less bearing down, less vagal activation, the easier, less stress you're going to cause on the cardiovascular system. And then just general relief of temporary constipation is going to be a common thing you'll see as well. Recall though, remember that, some of these things are available over the counter. Patients may be self-medicating, so they could have underlying issues like, for instance, Crohn's disease or ulcerative colitis that you want to make sure is being managed first, and then kind of deal with the other lingering issues after that is taken care of, which we'll talk more about those inflammatory bowel diseases here in a little bit. So again, you can find that in terms of general side effects for the laxatives, you're going to find typical abdominal cramping, diarrhea is a possibility, nausea. This all makes pretty good sense because, again, we're trying to stimulate things to move on through the GI tract. Chronically, you can run into some issues as well. So this can be a problem. And you may think like, okay, well, can people abuse laxatives? Well, actually they can, especially if you think about patients who have like eating disorders or something like that are really concerned with losing weight. They may try to abuse laxatives in order to try and lose weight more effectively. They can develop things like cathartic colon syndrome, which is basically trying to cause kind of long-term damage to the GI tract, which may make it more difficult for them to have normal stooling in the future. So the malabsorption issues, and you can disrupt the intestinal flora, make them at risk for other things like C. diff and things like that. So a lot of issues that can pop up from this. So when talking about the general group of laxatives here, we're going to find that there are some that soften the feces. This is good for, not immediate treatment, but can be helpful in the course of, say 1 to 3 days or so. So we'll talk about our bulk forming agents. We'll talk about some of the emollients, which help to actually kind of emulsify and help to try and make the stools easier to pass. And then our osmotic agents. Notice the osmotics are going to kind of come up in 2 different places here, which we'll see they're used a little differently. We'll have some stimulants that will work a little bit faster than that, usually about 6 to 12 hours or so, that directly stimulate peristalsis in the GI tract to try to move things out. And then we'll have some that basically just kind of overload the system and cause a watery evacuation. Probably 2 words you never thought you'd hear used together, not referring to like a diving incident or boat accident or something like that, but that's what we're going to cause here. And this can be very fast acting, right? So this is like patients coming into the ER complaining of abdominal pain, and you want to fix them right then. This is the stuff we're going to be using: our osmotic laxatives, some of the enemas, and then also talking about our bowel cleanouts. And again, I can't express to you, it's really important, especially for kids, to make sure that they have good variety in their diet. They're getting fiber, getting hydration, because every time I work, and I worked yesterday at the children's hospital, I always see a couple of patients getting admitted for a bowel cleanout, and it is not great for them because they have to get an NG tube placed. They're getting admitted to the hospital, getting all these laxatives just to clean them out, and it's really kind of unfortunate for them. And so if you can prevent that, a huge help, right? Okay, so getting into the different categories here. So let's talk about the bulk forming laxatives here. These are typically going to be some sort of like non-digestible fiber. You can see here, certainly people can get fiber from their diet for sure, but oftentimes they may need a little bit of extra help with this. And so this is where things like psyllium husk, Methylcellulose are going to be pretty common here. So if you hear about, Metamucil, like grandpa taking his Metamucil or something, this is what we're talking about here, trying to prevent constipation from happening or treating sort of run-of-the-mill occasional constipation. Basically, what these are going to be doing is they oftentimes will come in powders most frequently. You have to mix them up with water or some other sort of liquid, and ingesting those will end up causing a bulk to form, basically. All right, you're increasing the mass of the stuff that's sitting there in the GI tract because it's non-digestible. It's not going to get absorbed, and so it'll also help to draw water content in as well, right? If you cause an increased osmolar load in the GI tract, it's going to draw water to it, and again, that increases the motility here, right? So note here, though, there are going to be some issues with this. And again, this is stuff you're going to see like over the counter in a lot of grocery stores and things like that. So people are taking this at home. This is not something you'd likely be prescribing super often. But be aware of some of the interactions you're going to run into with it. These will frequently bind with other medications. And so you got to make sure that if patients are using these, and remember, if you ask them, hey, what medications do you take? They may not mention these because they may not really think about them as medications. So make sure you're inquiring about things like fiber supplementation and other dietary supplements, because it could be a reason why they're not absorbing their drugs effectively because they're taking them together, for instance, right? Other common things, flatulence, cramps, you're going to find that with most of the agents we're going to be talking about here in terms of side effects. All of that kind of makes sense, right? Next, we have some stool softeners. These are going to be things that help to emulsify the stool, help to increase their water content, and kind of lubricate things, make it a little bit easier for this stuff to pass through the rectum, right? So especially if they have those like really hard, sort of difficult to pass stools, this can be really helpful for that. We have things like glycerin, we have things like mineral oil, and docusate. Those are kind of the main ones. Occasionally you're going to find mineral oil used either PO or it can sometimes be used as an enema. You may see that. Glycerin we mentioned back in the peds section being pretty commonly used for infants. So kind of in that first year of life or so, we see glycerin suppositories being used quite frequently. And then docusate, which is a common oral agent you're going to see being used for kind of routine maintenance of constipation, especially for patients who are on like chronic meds that are constipating, like anticholinergics or opioids or something. You may find them frequently taking docusate to make sure that they can still stool somewhat normally, right? So next up, we have the stimulants or the irritant laxatives. Kind of two names for the same thing. These are interesting because they kind of directly stimulate receptors in the GI tract to cause colonic motility to increase. So these are going to work a little bit faster than something like a docusate, right? Docusate may take a couple days to really be fully effective because it has to get in there, emulsify the stool and all of that. Stimulants are going to be a little bit quicker. That's why it was in that 6 to 12 hour kind of range there where you see that. And, this is where home remedies have been used in the past. Things like castor oil has been used before to increase motility and all of that. Nowadays, though, in terms of like actual drug products, we're more likely to use something like Senna or Bisacodol. Those are the two common stimulant laxatives you're going to run into. Frequently, you're going to find a combination of this plus a stool softener. So if you ever see like Senna plus docusate, that's a pretty common combination that you'll see used there. In fact, we do this frequently for our patients who are admitted after surgery. So for instance, imagine if they had like a big spinal fusion procedure that was 12-hour long surgery, and maybe not 12, maybe like 8-hour long surgery, and they're being admitted. They're on opioids post-operatively because it's a very painful procedure, and the risk for being constipated is pretty high. They may put them on a combo of a stool softener plus a laxative, or a stimulant laxative, in order to make sure that they can still pass things somewhat normally. So very common to see that combo. Now with stimulants, though, you want to make sure that patients are not using these chronically. So that's a really huge patient education point. If you use them for the long term, you're going to find that your GI tract gets used to having that around. You develop sort of a physiological dependence on this stuff, to where if you were then to take the stimulant away, you can end up developing rebound constipation, right? So this kind of goes back to the same kind of mantra we talked about with like Afrin, for instance, causing rebound nasal stuffiness or rebound hyperemia. The same thing can happen here. So we really like for them to use it for as short a time frame as possible. So in the post-operative period, that makes good sense because they're on it for a few days and then they can get discharged and they're good to go. Probably don't require it any longer. As opposed to someone who's using it every single day, you may find that withdrawal is going to be very difficult. And so they may have to taper them down over the course of, say, days to weeks to months, depending on how big of a degree of dependence has developed there. So that's a unique thing with the stimulant laxatives you want to be careful with, right? Now, the osmotics, this is a pretty large group of different drugs here. Some of these are going to be used as sort of like daily sort of maintenance of normal stooling that you'll see, and I'll talk about a few examples of that. Some of these are going to be used more for acute evacuation of the bowels, and so I'll talk about kind of how we use these a little differently here. But again, they're osmotic agents, so they're hyperosmolar, especially when they get into the colon, and they will then draw water in, and that stretch and that increased volume in the colon causes that stimulation and motility to cause defecation here. Some of these will be available as enemas. I'll talk about a few examples there. And then a lot of these are going to be used orally as well, so that way they can kind of work from the top down to stimulate that. Again, benefits of oral versus rectal is mainly patient compliance. Rectal tends to be a little bit more invasive. Patients may not really want to be compliant with that, but again, it just depends on the situation there, right? So anyway, so things like mag sulfate, we talked about mag hydroxide being milk of magnesia. We talked about that being used previously as a laxative agent. Frequently, you'll hear milk of magnesia called the green rocket. It actually comes in a little green, actually kind of a large green bottle that is carbonated to help out with the sort of the palatability of it, because again, it's real kind of salty tasting. We call it the green rocket because patients will take it and all of a sudden they're off like a rocket to the bathroom, and you know that the drug has worked if you see that sort of reaction there. So little colloquialism of medications. Other things like lactulose, mannitol, you can see used here. I'll tell you pretty frequently, you'll see in terms of enemas, sodium phosphate enemas or fleet enemas are done all the time. And I talked about them briefly in the peds section. With these, you want to make sure patients are not overusing them, especially if they're really young or really old, because of the fact that you can cause some major electrolyte disturbances. If the AA's even come out and made some recommendations about saying, hey, avoid these in patients of extremes of age, either old or young, because you can cause hyperphosphatemia, and that has killed before as a result of overusing these fleets enemas. So if I see, like, for instance, like, a provider is trying to order a fleets enema for like a 6-month-old patient, I get a little bit concerned about that, especially if maybe the parents have tried it at home. Now they're trying it again in the ER. I get a little concerned from that. If they're older, if they're like 2 or 3, they can probably tolerate that, right? If I had someone who was like 95 and they're constipated, a fleet enema may not be the best option for them from that standpoint. We got some other things we could try that helps to not cause, electrolyte disturbances. So a big one that we use nowadays that is kind of circumvents a lot of those problems is polyethylene glycol, or Miralax, as you might see it, especially for like over-counter varieties, or Go Lightly, as some of you might be aware of if you've worked in the hospital setting or dealt with any sort of bowel cleanouts prior to surgery. So this, again, works just like something like sodium phosphate. It's just a hyperosmolar compound that when it gets into the solution in the GI tract, absorbs more water in, increases motility. For a long time, Miralax, just like most drugs, was brand name only, but now that it's gone over the counter, you'll see this used pretty frequently at home. This can sort of replace a lot of like the fiber supplements that people would use. So if they don't like necessarily like the palatability, or they can't tolerate something like psyllium husk because it can get really grainy and it doesn't necessarily taste great. You can actually use Miralax as an alternative, and that works pretty well. You could use this every day and it's no problem. It goes into solution really easily, and it also is tasteless. So a lot of people like it from that standpoint. Probably a little more expensive though than something like a Metamucil or something. So that's like for daily maintenance. For clean out, and so this is where I would use it if I had someone who had overdosed on lithium, for instance, or if you needed to clean out someone's bowels prior to surgery. This is where you get have the Go Lightly. And basically, it comes in this big, like 4-liter jar base. Not jar, it's more like a plastic container, but it's 4 liters. And you have the polyethylene glycol in there. You put it into solution, and the patients have to drink that. And again, it's called Go Lightly, Lyte, because it has electrolytes in it to make sure that there's no shifts that occur within the GI tract. So that way patients should not have any kind of electrolyte disturbances by using this. Because again, the goal when you're using Go Lightly is to get things completely flushed out from the GI tract, right? So that way if you're going in for surgery, you can see things better. If you have a toxin in there, you can flush it out. I actually had to do this pretty recently. I made the recommendation for a patient who had gotten into a motor vehicle accident, and then they ended up finding when they brought him in, they actually did an x-ray for the patient, found a bunch of packets of something in the GI tract, ended up being cocaine that the patient had, packages of cocaine the patient had swallowed to try to avoid legal repercussions. And maybe that preceded the motor vehicle accident, who can say. And we actually recommended using Go Lightly to flush that out, because if cocaine gets released in the GI tract, it can cause a lot of problems. The page is asking how quickly does it work. It can work within 30 minutes to an hour if you can get it running. So, and again, with Go Lightly, it doesn't taste great, because some people has kind of equated it to tasting like warm sweat because of the electrolytes that are in there. So palatability is not great. So frequently what we end up having to do is place an NG tube, and then that way we can actually run it on a pump, and that way the patient doesn't have to worry about actually drinking it. Yeah, it's pretty gross, but you know, you have a belly full of cocaine, I'd rather drink warm sweat than have that all that cocaine release and then cause mesenteric ischemia, and I die from that. So, you know, take it good with the bad. So anyway, so we ended up using that. You know, we'll do this a lot for these kids that get admitted for constipation, where they need a bowel clean out. So that's the ones I see, you know, at least 2 or 3 admissions every time I go work. You know, like I mentioned, I recommend it from a toxicology standpoint, so you'll see this used quite frequently. At least they keep it interesting. Yes, definitely. You know, I always thought the name Go Lightly was funny, because there's nothing light about how these patients are going, because it is a watery evacuation, so there's a lot of movement that's going to be happening in there. And frequently, like what we're looking for from like a tox standpoint, we talked about clear rectal effluence. I want everything gone from that GI tract. This is a pretty effective way to do that. So this is probably the most common thing you'll see there. Okay. One thing to note when you're dealing with patients who are neutropenic, which you may find with like patients who are on chemotherapy, you may find lots of reasons. Make sure you're not using any rectally administered drugs, okay? The reason why, and that would be like an enema or something like that. Also, you don't want to do things like taking a rectal temperature, any kind of like digital rectal examinations, anything like that, because of the fact that, remember, why are they neutropenic, right? If it's because of something, because these cells are not able to replicate like normal, you can find that the rectal tissue can become friable. Friable is a good adjective I like to use, which means basically the tissue becomes sort of brittle and very easy to break. And so what happens for these patients is you can have translocation of, you know, due to just tissue injury happening due to inserting enema, for instance. You have translocation of bacteria into the body, and then the patient has no neutrophils basically to fight off that infection. They can get septic and die from that, right? So that's why you want to be really careful if you have neutropenic patients. I think I probably mentioned that back in the chemo section last semester, but you know that still stands here. As I mentioned, be careful of sodium phosphate enemas in the very young and the very old, as I already talked about there. Someone had a question. Let's see here. Someone that if you get withdrawal from stool stimulant, can they keep taking a stool softener to help? I would probably recommend that regardless. Yeah, they can still take a stool softener by itself. There's no physiologic dependence, because that's just making the stool itself easier to pass, as opposed to the stimulant laxative working directly on the GI tract itself to cause movement to occur. So in that case, yeah, they could use other things. They could use bulk forming laxatives. They could use osmotic laxatives. Any of those would be fine there, right? Alyssa was saying, lots of clean out kids at me and Nicole's old job on the general peds floor. Yes, and it's always like made me really worried about my kids. I'm like, please never let this happen. I would feel really bad if I had to get my kid admitted to the hospital because of constipation. Now, certainly there's like medical conditions that can cause that for sure, but you'll find in a lot of cases it's just like, you know, their diet mainly consists of like chicken nuggets and mac and cheese, and they don't get enough water, which again, I am definitely you know, guilty of giving my kids a more brown sort of color of food a little more often than I would like, but you know, it is what it is. So yeah. Anyway, let's see. Nicole's saying I worked on a peds unit, and we had typically had 2 patients on the unit every time I work with Go Lightly. Definitely nothing light about it. Yes, it is definitely something else. Yeah. Anyway, so someone's asking, does Miralax or psyllium affect absorption of nutrients? It could. And good job on using affect appropriately. Yes, you can find that you know, there could be malabsorption issues. I typically find that patients are using this like 1 time a day, usually like in the morning, for instance, and that will, you know, leave all their other meals throughout the day are probably not going to be necessarily affected by that. So you probably wouldn't run into too many issues with this. I wouldn't expect, but you know, there could be some fringe cases where that could occur. Okay. Switch back. Sure, I switch back now. So, anyway, so if you're treating a patient who's complaining of constipation, make sure you're looking for the specific cause. You may not always be able to treat that. So, if they're on something like chronic opioids because they have really bad pain, it may not be feasible to get them off of the opioids necessarily, right? So, there's some things to consider. Regardless, dietary modification is a big thing to recommend, increasing their fiber and their water intake. I don't know if I never, and I'm probably aging myself, but there's this old SNL skit from a long time ago where they talked about this cereal called Colon Blow. They talked about how much fiber was in the cereal, and it was like a huge mountain underneath this guy of all the cereal. But like, increase their fiber intake. You'll not believe how much that will help out a lot of these patients here because they probably have very little non-digestible fibers as it is. Um, Starting off, you can try either like an emollient or an osmotic laxative, usually like a 2 to 4 week trial to see. Again, you're shooting for like, once a day generally. If they're still not having a bowel movement for about 2 days or so, that's where you can add on a stimulant. Okay. Occasionally, what we're going to do for some patients, especially like post-operatively, and I'll talk about this later when I talk about opioid reversal agents, but there are some antagonists you can actually use that work just on the GI tract. Don't worry about this now. I'm going to talk about that at a later date, and we'll get more into details on that. And then if you need acute evacuation of the bowels, this is where osmotic enemas are going to be very handy, or you could do something like a Go Lightly, which is typically given orally or via NG tube, or if the case may be. So that will help to kind of flush things through. Again, watch out for sodium phosphate enemas in the very old and the very young because of the risk for life-threatening hyperphosphatemia. Okay, we do have a couple agents that are going to be antidiarrheal, so this can actually slow down GI motility here. And so not too often are you going to see this will not be as recommended as often because frequently if they're having diarrhea, it's probably for a reason. And especially if it's infectious, you may not necessarily want to prevent whatever is causing that infection to be sticking around, basically. So again, these are going to be things I would recommend sparingly. But for occasional diarrhea, this could be fine, especially if they're like, traveling and they go somewhere and it's not infectious, but it's like, they're just not used to the diet that they're, the food they're consuming there, something like that may be reasonable. Now, interestingly, these are actually opioids. These are opioids that, just like I mentioned before, opioids slow down the GI tract. These are ones that don't cross the blood-brain barrier. And I think I told that anecdote as someone who was taking too much loperamide along with cimetidine. I was trying to get a drug interaction there, but basically, these cannot cross the blood-brain barrier very easily, and so they stick out in the periphery and will work on the GI tract to slow things down by activating those opioid receptors. And interestingly enough, for instance, diphenoxylate or Lomotil actually gets compounded with atropine because people were concerned about people taking these tablets, crushing them up, and trying to inject them. They went ahead and put atropine in with it because the concern for basically if you inject that atropine, it's going to give you a really, really bad time because you're just going to feel miserable anticholinergic wise. You're going to have all that dry mouth and CNS effects and the Mad as a Hatter effects. The idea was if these patients wanted to inject it, the high they would get would be so miserable because the atropine, they just wouldn't do it anymore. So we call that an abuse deterrent. There's a few other examples of that I'll demonstrate, especially in the opioid lecture. But that's the reason why I see the atropine there. It's not because of its antidiarrheal effects, because atropine doesn't really have very good absorption. It's mainly to prevent people from injecting the drug in order to get a high out of it. So obviously constipation is going to be the main side effect you're going to see here. And keep in mind that they're kind of abusing these chronically, can develop kind of a megacolon sort of thing where they're just having way too much backup that can cause some injury as well. Now, bismuth itself can actually help out. It is, kind of loosely an antidiarrheal agent, can be effective for some cases of infectious diarrhea. Remember that bismuth has some antimicrobial activity and can help out with some of the kind of increased secretions you'll see there. So just be aware of that. In terms of salicylates, obviously young kids, especially if you're worried about viral illness, you want to be careful with the Ray's syndrome. Bismuth toxicity is not common. This would be more so in patients who were maybe having a renal dysfunction, something like that, where they could not process it, but you'd be less likely to find issues with the bismuth, but mainly salicylates in those young children. Okay, hopefully that makes a sense so far. Let me see questions here. Okay, so getting into inflammatory bowel disease, and then we'll get into irritable bowel syndrome. So I'm not sure if you guys have covered this yet, but if not, it's your first time getting it. Mainly when we're talking about inflammatory bowel disease, we'll cover or break this up into ulcerative colitis and then Crohn's disease. Mainly the big difference here, at least to my mind, is what portions of the GI tract are going to be affected. The reason why I try to divvy it up like that is because it makes me think about what type of dosage forms are going to be appropriate for the individual disease stage, right? So ulcerative colitis means it's mainly affecting the colon, versus with Crohn's disease, it's much more likely to be more diffuse and could affect, almost the entire GI tract, basically, right? So basically what we're having here, and this is actually going to be a good segue when we get into the rheumatology section, because you will find for these autoimmune conditions, there's a lot of crossover in terms of medications, right? So the stuff you're going to see used for rheumatoid arthritis may have some crossover here in treatment for inflammatory bowel disease, because the pathophysiology to some degree is quite similar. Your immune system is overactive. It's fighting off your own tissues to cause these problems here, right? And so, again, you're going to find that the main ways we're going to treat this is to try to tamp down the immune system, to try to prevent it from being overactive and affecting all of our, our precious GI tract here, right? So, again, I'm sure getting into the pathophys more specifically in CMS. I just want to touch on that briefly here. Anyway, again, when you find that these immune cells are attacking this tissue, here's where you'll end up with a lot of the inflamed mucosa. This is where you lead to a lot of like the malabsorptive issues and all the problems that come into this. And again, this inflammation can even lead to perforation of the bowel in some cases. It can be so severe. So it's certainly something we want to get under control. So let's look at the different agents we're going to use here, and again, kind of listing them out here so you can kind of see how they're being used. And then we'll look at the ways we use them specifically. So you'll find that a lot of the treatment is quite similar between the two. You're going to find that, because the pathophysiology is similar, we're going to use very similar drugs in order to treat this. But some of the dosage forms that we're using is going to be a little different, as we'll see here in just a little bit. So with ulcerative colitis, we're going to talk about our aminosalicylates. Salicylates should already kind of trigger something in your mind thinking, oh yeah, salicylates are anti-inflammatory because they kind of work like NSAIDs, right? They block activity of cyclooxygenase. Corticosteroids are going to be really important for a lot of these patients for really any kind of rheumatologic condition or autoimmune condition, whether it be lupus, whether it be some kind of renal autoimmune condition, all kinds of stuff. We'll talk about specific immunosuppressants. We'll talk about a few monoclonal antibodies, which are now starting to become much more common and prolific in treatment for these rheumatologic conditions. About some probiotics briefly, nutritional support, and then surgery may be an option for some of these patients. And then for Crohn's, basically all the same drug classes can be used here. There may be some benefit for antibiotics and some antidiarrheals as well, as we'll see in just a bit. So, what's our goals here? We want to resolve the inflammatory processes, right? And you're going to see a lot like with other things like asthma, for instance. You're going to have cases or times where things kind of go and they kind of mellow out a little bit, and maybe you can kind of scale back some of your medications. And then there's going to be flare-ups where we're going to have to try to increase the number and intensity of the meds that we're giving in order to get things under control, to get them back to that sort of mellowed out kind of resting phase there, right? Obviously, if we can resolve any complications, especially if they're developing like infectious issues like abscesses and fistula and things like that. And then again, that maintenance of remission is really important. And this can be tough too, especially if like younger patients who don't want to be on all these medications. They hate the fact that they got dealt this crummy hand in life. You'll find that patients will just say, I just don't want to take these meds anymore. And they just go off their meds. And that causes a big flare up in a lot of cases. So maintenance of remission is really important. And again, dealing with all the other stuff that's going on, especially from a behavioral health standpoint, is super important to keep these patients, being adherent to their therapies. You'll find maybe some mild to moderate cases may resolve or improve on their own, but a lot of the more moderate to severe cases are definitely going to require indefinite therapy. They may be stuff the rest of their life in some cases. So let's talk about our options here. So first off, we have the aminosalicylates. Sulfasalazine is probably one of the more common ones you're going to run into. This is actually a prodrug. If you recall, prodrugs meaning that in its initial state, it is inactive. It doesn't do anything. It has to be metabolized and broken down into its active components. In this case here, you'll find that it breaks down into a product called sulfapyridine and then 5-aminosalicylate, or aminosalicylic acid. So another name for this is going to be mesalamine, as we're going to see here in just a slide or two. The 5-ASA, or mesalamine, is the other active component here. And again, it's actually the colonic bacteria that does this metabolism. Normally when we think prodrugs, we're thinking about the liver doing the metabolism into the active components. Here it's actually colonic bacteria. So we're putting those freeloaders to work finally. They're just sitting there thinking they own the place. Let's make them do something for us, right? Besides all the other healthy things they do for us. But By having this 5-amino salicylic acid on board, this actually will cause a local inhibition of cyclooxygenase and the lipoxygenase enzyme systems, and that will help to reduce the inflammation. Right. So these are either going to be administered orally or they may be administered rectally, depending on where the inflammation is, and they're working very locally. So the benefit of doing something local like that means that you can help to limit a lot of these systemic side effects you may run into. Okay. Most of the side effects you're going to see tend to be more GI in nature because they are working so locally. And again, a lot of this stuff you're going to run into as part of their disease state anyway. So it can be difficult to determine, well, is their disease state getting worse or is it the medications causing the side effect? And that can be tough. But again, getting good history, getting good story from the patient may be able to let you know one way or the other. You can see some blood dyscrasias. If you recall, sulfapyridine kind of fits in that same category as something like sulfamethoxazole. So you can have some rare cases of blood dyscrasias, but it's not super common, or at least not as common as we're going to see with some of the other meds we'll look at in just a little bit. So the other way we could do that is just to give the mesalamine by itself instead of having to worry about having that prodrug, the sulfasalazine, being broken down. Just give the 5-ASA, right? That way you get rid of the sulfapyridine. Remember, sulfa has a sulfa moiety to it. Some patients may be allergic to that. You probably want to avoid that. Here, though, you kind of get around that problem. And so I just want to give you a few examples of the different ways we can actually administer this, as you'll see in just a second. Same exact mechanism, though. So, and again, you're going to have less adverse effects because you're not getting the sulfapyridine. So it's a little bit more of a pure drug. I probably see more mesalamine being used than I do sulfasalazine, as it turns out. At least that's anecdotally what I see. And so again, depending if they have ulcerative colitis, you probably want to just make sure the drug's getting to the colon. And so there's some ways we can actually do that help to mitigate this. Shelby's saying, why even use the previous one if this one is so much better? I think it depends on the case. Again, there are some benefits to the sulfapyridine, having some anti-inflammatory properties, but again, this is just what I see more commonly. I've seen some patients on sulfapyridine, sulfasalazine. I think a lot of it may be up to the GI provider. Again, I don't deal with this like chronically in a lot of cases, so I'm more frequently seeing patients come in for admissions where I'm kind of working through their home meds and seeing what we want to continue or discontinue. So if you talk to someone who works in GI, might be able to give you a little bit better idea of when they might choose one versus the other. It's just not something I'd have a lot of input on that decision in a lot of cases. Anyway, so looking at this, so obviously if you have something like Crohn's disease where the disease is going to be more diffuse throughout the GI tract, you probably want something taken orally, because if I try to give an enema, there's no way I'm going to get all the way up through, the small intestine. There's just no way that's going to happen unless you, I don't know, put a pump on it or, some kind of, I always think about those power washers or something. Maybe that could get up there, but that's not really feasible for a lot of patients. So instead, oral options are going to be good for patients that have more diffuse disease, Crohn's disease, basically. On the other, so you'll see things like Asacol, for instance, Lialda are going to be these tablets that you can take. Notice here the actual dose is pretty large compared to a lot of other medications you'll see there. It's like 4.8 grams. So usually they're pretty large tablets we're administering. On the other case, so you could get away with using something that is going to work more locally. And for instance, if they just had like a proctitis associated with this, well, just give something like a suppository. That would be totally effective. And again, that local action helps to mitigate a lot of the more systemic side effects. In the case here with something like Roacid, this is actually an enema that will be administered, 60 mLs, and that way it actually works better for left-sided disease. And I'll show you a picture of this in a moment, but kind of the left side of the colon is kind of as far as you can reasonably expect an enema to really get, just based on the anatomy of the patient and the fact you're dealing with gravity and all that kind of stuff. So enemas are going to be good for left-side disease. If it's past the left side of the colon, you're going to find that more oral options are going to be your better bet there. And again, I'll show you some graphs here in a moment. So looking at the product, you can see how and where it's actually going to be able to get depending on the different dosage forms we have here. So for instance, with like a mesalamine suppository, yeah, it's just going to be working in the rectum. That's specifically where it's sitting and melting and working. Versus an enema, you may be able to get distal portions of the colon. Some of these may be able to get a little bit further in, but for the most part, you're going to require oral options in order to make sure that you're getting the entire small and large intestine being affected here. So diffuse disease, you want to think oral options. If it's going to be more left-sided or proctitis, or left-sided colitis or proctitis, think rectally administered medications, right? So kind of be able to kind of determine that based off how, if I give you like a patient presentation on a test, be able to pick an appropriate product. But just say they have a proctitis, you don't need the enema. You can just give them the suppository and that would be reasonable, okay? Okay. A couple other agents you'll have here. So things like osalazine, which is actually just a dimer of mesalamine, meaning it's two molecules of that put together. It's a prodrug. And then basalazide, which is a prodrug that actually has an inert carrier molecule that you can just pass through the stool, no problem. The 5-ASA is there. And again, you're like, well, why do they have all these other drugs? Again, there could be financial incentives for companies to come up with a product in order to, treat this, how many ever millions of people that may have this disease state too, right? Again, that's why, it's like, well, why do we have multiple ACE inhibitors when we could just use one? Because, people want to make money, and so they want to make drugs that can also be used to treat that condition as well, right? Okay, so corticosteroids are also pretty interesting here as well because, again, we recall, especially with like stuff like asthma and other disease states, that corticosteroids have a whole host of side effects. We know they're immunosuppressive, which is what we're using them for here. We know they can cause issues with like hyperglycemia. They can cause issues of hyperlipidemia, all kinds of other problems that can develop from chronic use of corticosteroids. So if we can do anything to limit the systemic effects, that's going to be very beneficial. Just like we use inhaled corticosteroids for asthma, we can try to use things that are going to work more locally in the GI tract. Okay. Now, this may not always be appropriate. Sometimes you're going to need systemic therapy, especially if they're having a big flare-up, okay? So just like we saw with asthma, if you're having an asthma exacerbation that, albuterol is not cutting it, you may need, like a 5-day course of prednisone or something. Kind of a similar sort of mantra here, as you'll see. And again, this will come up with the other rheumatologic stuff we'll talk about later on. But let's talk about a few of the topical agents that we have here. So hydrocortisone is a very common one. Remember, hydrocortisone is basically the same thing as cortisol that you make in your adrenal glands. So same exact product here, right? And that stream's hiccuping a little bit. Hydrocortisone is also, if you recall, when we talked about derm stuff, is pretty much like kind of the wimpiest of the corticosteroids that are out there, which means it's going to have the least amount of side effects. But when given locally, you can find that can be pretty effective at working just there on the tissue. So for instance, with the hydrocortisone, we have like suspension enemas, foams, we have suppositories, things we can use for more distal disease. This is going to be more so for like ulcerative colitis in a lot of cases, right? So you can see here as an example, Colocort, comes as a 60 ml enema that you can use per rectum, right? PR, daily or twice daily. Am I going to ask you what dosage forms does hydrocortisone come in? Probably not. I want you to think about, though, why you might use one dosage form versus another, okay? Why do we use topical corticosteroids as opposed to just giving everyone systemic steroids? That's the kind of stuff I want you to think about. And again, when I'm saying topical here, is probably as confusing because when you think of derm stuff, you think topical administration. I'm being topical in terms of like not getting absorbed systemically. It's just working on the GI tissue that's there. If you kind of think about humans as being like kind of one long tube, you can kind of think about us as still being topical in that sense there. If you've never thought about yourself as one long tube, there you go. You now have that in your brain. Couple other options we have there. Sometimes you're going to see oral budesonide being used. And if you recall, we talked about budesonide in the past being used for like nasal use or inhaled use. Budesonide is actually nice from a side effect standpoint because it has really extensive first pass effects. So very little of it that does get absorbed is actually going to pass the liver and affect the body systemically. So that can be really good for more chronic use for these patients. And again, taking it orally is going to be able to affect most of the GI tract as opposed to something like a rectal hydrocortisone only affecting whatever areas of the tissue that it touches, right? So that could be good for chronic use. For flare-ups, that's where you're going to get into using stuff like prednisone, methylprednisolone, the really, standard sort of systemic steroids that we've seen over and over again in the past there, right? From an IV standpoint, if a patient's having to be admitted, maybe they're having a bout of like bloody diarrhea and maybe they're having a big flare up because they were not compliant with their meds or whatever the case may be. This is where we can utilize IV corticosteroids like methylprednisolone, hydrocortisone, dexamethasone. Any of those are totally fine. Of course, if they're getting more systemic effects chronically, right? Because maybe they're having their flare up for a couple of weeks or a month or two. This is where you're going to run into those problems of glucose intolerance and weight gain, all those kind of things you would normally expect to see with corticosteroids. Someone had a question here. Someone said, sorry, I'm a little behind. No problem. That's why I do the YouTube thing, so you can rewind me if you need to. PowerPoint states, delivers mesalamine to the colon where it is not absorbed. Is this stating that it brings the drug to areas where it wouldn't usually be absorbed, and that's what makes it effective? No, it's just getting into contact with the inflamed tissue. So if you were to give like a mesalamine enema, sorry, I get mush mouth after a while. If you were to give them a salamine enema that's going to just come into contact with the left side of the colon, that tissue, that's where that's inflamed. That's the only place that's going to be affecting it. It's not going to affect, more proximal portions of the colon. It'll have its anti-inflammatory effect and then not get absorbed. So you don't get the salicylate effect systemically, for instance. So that's what I'm talking about, using it topically where it doesn't get absorbed. Just affects that really inflamed tissue right where it is. So that makes less sense. Okay. So we have the corticosteroids. We talked about the aminosalicylates. Now let's talk about some immunosuppressants. These are going to be drugs that are used either to suppress the, say, the reproduction of white blood cells. So some of these are going to look similar to what we saw when talking about chemotherapy a little bit. And then we're also going to have some that are going to be directly affecting different cytokines that are going to be produced in the inflammatory cascade. Okay, so for instance, some of these we already looked at. Like we looked at something like 6-mercaptopurine before. We looked at stuff like methotrexate before. If you recall, methotrexate is a folic acid antagonist, right? Remember, it prevents utilizing folic acid to produce new nucleotides to form new DNA. And remember, what cells get mostly affected by drugs that arrest the ability for you to produce new DNA? What's rapidly dividing cells that are undergoing quick bouts of mitosis. And so your immune cells get affected, right? GI cells get affected. Your hair cells can be affected. So the immune system effect is what we're looking for here to try to suppress that. Now, imagine someone who has ulcerative colitis versus someone who has leukemia. Leukemia obviously is a huge problem with your white blood cells reproducing like crazy. You're going to need much higher suppressive effects of something like methotrexate for that, because you want to get rid of all those cancerous cells, than for someone with ulcerative colitis who just needs their immune system kind of tamped down a little bit, right? So because you're just trying to chill it out, you don't need nearly as high doses. So this is why you can see something like for methotrexate given systemically for cancer, you may see grams and grams of it being given because you're trying to wipe out all of those cancer cells. Here you may get 25 milligrams of methotrexate weekly, right? The doses are much lower for rheumatologic conditions and autoimmune conditions than you would see than for cancer, right? And that should make a sense to you if you kind of think about what kind of effects you would see based on a dose response sort of scale there, right? So with the thiopurines, again, these are working a little differently than the methotrexate, but ultimately the same thing is happening. You're preventing DNA and RNA synthesis. Those white blood cells cannot reproduce as fervently, and thus you're going to help suppress the immune system. So keep in mind too that these may take longer to work. So in terms of onset of action, may not be super quick. So like say for instance like 3 to 6 months to get the effect of the thiopurines, like azathioprine, 6-mercaptopurine, take a while to kick in, right? Remember, common side effects for these drugs are going to be things like the myelosuppression, which can lead to infections, right? Those are really the big things we are concerned about long term. And certainly, some GI effects can happen here as well. Remember, methotrexate can also be kind of rough on the liver too. So you want to be cautious with that. Make sure you're monitoring LFTs and all of that good stuff. Now, so those are ways we can actually suppress the immune cells from actually reproducing. What if I just wanted to be more targeted and just affect the specific cytokines? You could do that too. And so this is where we get into something like cyclosporin. And you'll see cyclosporin being used for a lot of different conditions, both autoimmune conditions. And you may also see it being used for things like organ transplant to prevent rejection, right? So graft versus host disease. You can prevent rejection by suppressing the immune system. So for a lot of those transplant patients, if they get lung or liver or whatever, they'll be on corticosteroids frequently to suppress the immune system, and they'll be on stuff like cyclosporin to again affect specific parts of the immune cascade. In this case here, it actually prevents release of IL-2 or interleukin-2 from the T cells. So if you can't release that, then it doesn't have its kind of downstream effect of activating all these other immune cells and doing all of that. Again, it's meant to sort of just kind of chill out the immune system a little bit to prevent all that inflammation from happening at the GI tissue, okay? Obviously here, infections, again, is going to be a big risk, just like with all these other immunosuppressive drugs. So that's a class-wide sort of effect. Other problems you can run into with cyclosporins, you want to watch your blood pressure because it can actually cause hypertension, and you can see some nephrotoxicity. So watch out for their renal function. Monitor that at baseline. You'd follow up and make sure it's not taking a nosedive anywhere, right? Okay, so the next thing we're going to look at are going to be our monoclonal antibodies. And so this is pertinent because one of your prescription assignments is actually to do with Humira. So I'll take a little bit of time to talk about this. We've talked about monoclonal antibodies before. If you recall, these are antibodies that have been specially engineered to target a specific protein, receptor, etc. So we talked about them. You could use them for cancer. They can target certain CD receptors. We talked about them in terms of asthma. They could target certain antibodies. So antibodies versus antibodies. So omalizumab or Xolair was used against IgE, for instance. Same thing is happening here. They're just engineered for a different target. So we'll find some of these are going to be used against like interleukins, for instance, but I'm going to focus mainly on the TNF alpha inhibitor. So these are tumor necrosis factor. These are some of the big ones you'll see being used for ulcerative colitis and Crohn's. When we get into rheumatology specifically, I'll kind of expand this out and talk about some other ways we can actually manage that. So remember, these are monoclonal antibodies, so they're protein derived. So your risk for anaphylaxis is higher than it would be if you were to just use a regular drug like, a corticosteroid or something. But they're also more specific for that target. So you're not going to get as many side effects as you might see from something like methotrexate, for instance, right? Look at some side effects that can occur, but obviously the goal is here is to be more specific. So here we have infliximab and we have adalimumab. Most of the times these are going to have kind of gobbledygook names that are difficult to say. Remember, though, that if you see a mab on the end, it means it's a monoclonal antibody. So, but what's kind of different here is if you recall, I talked about how sometimes the naming here can actually give you a clue as to the source for the proteins that make up the antibody. So if you ever see an XI in there, that means it's a chimeric protein. It means it's mixing murine and human DNA together, or proteins together, in order to get the antibody. Murine meaning mouse, right? So a common side effect may be your patient wants some cheese all of a sudden. Totally normal, right? So kidding. Versus adalimumab, if you look, here's MU, this means it's humanized protein. So this is much more likely to just be human protein you're getting. So your anaphylaxis risk is lower with something that's humanized, meaning it's more human protein, than if it would be murine protein, right? And I run into this all the time too, especially dealing with snake bites, because the old antibodies we used to use were basically coming from horses. So we're giving horse antibodies to people, and they anaphylaxed all the time. But again, these are especially engineered, so hopefully that risk is going to be much less than that. But that'll lead to some of the side effects we run into as well. And a lot of this talk I'm doing here, it will kind of pave the way for when we talk about rheumatology as well. Other benefits you're going to see with these drugs here, they generally have a long half-life. The antibodies will stick around for a while, and you can kind of see that when you're looking at the dosing pattern. So, for instance, with infliximab, you're giving it week 0, 2, and 6, and then you're coming in every 8 weeks. So from a compliance standpoint, that's a little bit better because of the fact that you're only getting the drug every so often, okay? So that could be one benefit. Another thing you'll notice here as well is that some of these have to be given via IV infusions, right? So for instance, with Remicade, you have to go into a place in order to get an IV established to infuse the drug. Another big thing why they do that is to make sure that you don't have a reaction, right? Because with infliximab, infusion-related reaction is much higher. Risk for anaphylaxis is higher than something like Humira. So that's why they want you to be somewhere where you have medical providers around that can react to that, okay? Versus something like adalimumab or Humira, which is more humanized protein, the anaphylaxis risk is much lower. The infusion reactions are much lower. So notice here, you can give that sub-Q. So if you look at the dosage forms for Humira, they can just use it as a pen. It's basically a pre-filled pen with a needle that you can put on the end to inject it subcutaneously. So that's a big benefit because patients can do this from home. I don't have to take off work in order to come get my Remicade infusion. I can use Humira instead, right? You're like, well, why is that so much better? Why don't you use that for everybody? Because not everyone has like ideal reactions to these drugs here. Some people may fail Humira and have to go to something like Remicade, for instance. So it just really depends on the patient, how they're responding to this stuff. Other big thing, these drugs are expensive, really expensive. So it's important to make sure that we have, things like insurance coverage, available for this, because these cost thousands and thousands of dollars to administer. So really important from that standpoint. Okay, so kind of talked about how it has a long half-life, so that kind of makes sense why the dosing is so infrequent. Notice here some of the reactions you can run into. And so Shelby's asking, does it matter where they inject it? Generally speaking, it'll be on the abdomen. I think it's probably easiest for patients to inject themselves as opposed to anywhere else. Typically for IM injections, if they're self-administered, like an EpiPen, you'll do that on the lateral aspect of the thigh. But for sub-Q administration, like insulin, anticoagulants, like Lovenox, the abdominal tissue is totally fine, and just make sure they're kind of rotating around, because otherwise you can find issues that they inject the same site over and over again, like lipodystrophy and stuff like that. Anyway, but looking at like Remicade, it's really important that we have we worry about those infusion related reactions because again they're getting an immune response to this protein being sent in. So you're getting fevers and chills and they're feeling myalgias and stuff like that. So frequently we have to pre-treat them with things like acetaminophen to help out with the fever, right? We'll pre-treat them with things like corticosteroids and sometimes like methylprednisolone to prevent that inflammatory reaction to the actual protein itself. Even though the drugs are immunosuppressive, you can still have an immune response to the drug itself, which sounds counterintuitive, but it is what it is. Notice you'll see less of that with something like Humira because the protein is not mouse based, and so you're going to have less likely to have a bad reaction to it. Other things to note is secondary infections. So again, these are still immunosuppressive. So things like upper respiratory tract infections are more common. You really have to make sure you're checking for TB for these patients prior to starting their administration because patients could have latent TB. Then when they now have this immunosuppressive effect of stuff like Remicade on board, now all of a sudden it can then activate and give them active TB. So it's a big black box warning for these particular drugs here, saying, hey, make sure you check them for TB beforehand because the risk is higher if they do have an activation here. Other things as well, as you can see, CHF can be worse in here, so you would want to be careful when patients have a history of that. And those are kind of the big things you run into. There's some concern about secondary malignancies. I don't know if we had the full story on that yet, but it is potentially a concern if they're on it for years and years. So, but those are kind of the main things to think about with monoclonal antibodies. Anaphylaxis risk, think about they're not given quite as frequently. They're immunosuppressive. Remember, secondary infections are going to be more common. Those are kind of the things I want you to sort of think about. And again, with Remicade too, it's really important to make sure that if you're ordering these medications, they have anaphylaxis meds available in case they have a reaction. When I say anaphylaxis meds available, what does that mean? Well, frequently when they're ordering this stuff, we'll have order sets set up to where you automatically go ahead and order it. But you want to think about having orders on board to say, okay, well, if they have anaphylaxis, we'll make sure we use, and we talked about anaphylaxis before, epinephrine, a dose, ready to go for that. Corticosteroids like, methylprednisolone, diphenhydramine, things like that, in order to make sure that you cover that in case the patient does have anaphylaxis. So frequently they'll say, okay, epinephrine 0.3 milligrams, PRN, anaphylaxis. And that way the nurse can act if the patient does have a reaction, as if you're not around, for instance, to do the order itself, because nurses can't do those orders independently. See, someone said, with methotrexate at a much lower dose, are we less concerned about folic acid effects? Overall, side effects will be lessened with the lower dose of methotrexate. You still may want to give them some supplemental folic acid. It's questionable. I don't know that you're necessarily going to ameliorate any of those side effects, but it is something you could recommend. But yeah, overall, all the effects are going to be lower with that lower dose of methotrexate for sure. Okay. Now with probiotics, there's a lot of different varieties that are out there. That also makes it really difficult from a study sort of standpoint, from a research standpoint, to figure out, well, like, should we be doing this? What's the best one to use if we are? The idea mainly here is that maybe there is some of the pathogenesis for these conditions is due to altered gut flora, and so if we can reestablish normal gut flora or more healthy gut flora, then that would help to limit some of the inflammation that we're seeing here. Again, we're seeing that as time goes on, hopefully we'll get more studies. We'll have more information about what the most appropriate thing to do is. So you may recommend this. Some people may not be on it. It really just depends on the individual provider and what they want to do for that particular patient. So again, kind of a plus minus sort of thing. Okay, now antibiotics may be used occasionally for some patients. This will be more often in patients with like Crohn's disease, especially if they have like fistulas and they can have bacterial overgrowth that can happen here. And again, this, when we have this decrease in concentration of normal flora, you can get those, kind of those opportunistic bugs start to kind of accumulate, right? And so this is where we're going to run into some problems here. So the idea is to try to get rid of those bad bacteria and try to help out with having more benefits from the normal flora. So you may not find this all the time, but it's more often used when they develop those fistulas that are just kind of sitting there harboring bacteria. Something like ciprofloxacin or metronidazole is frequently used, some a little bit of anaerobic activity there. Other ones have been used before include like clarithromycin, tetracycline, but these two are the main ones that I would remember. If you had someone who had Crohn's disease with fistulas, that's probably the main thing you'd end up going with. Okay. So let's talk about like individual treatment between the two disease states when we get into that specifically here. So with ulcerative colitis, remember we want to get remission of their symptoms, reduce that mucosal inflammation, overall get better quality of life, right? And we'll see that their treatment is going to be more dependent on severity and location, right? Because is it just a proctitis? Is it left-sided? Is it affecting the whole colon? That will make a big difference here. Remember, if we are using topical products, a suppository is going to be good for the rectum and the distal portions here. An enema is going to be better for left-sided. Anything beyond that, you got to use an oral product. It's going to be recommended there. And so you can kind of go through with ulcerative colitis, you can kind of go through a step-by-step approach here. So again, this is kind of the questions I could ask saying, hey, patients on this right now, what would you want to add on to this? What would you want to consider doing in these cases here? So notice here, if it's a more mild disease, if it's, if it's something that's more distal, you can utilize something that is going to be like just an enema or suppository potentially, right? If it's the whole colon is being affected, this is where you want to be using oral products, like oral mesalamine, for instance, as a starter. So start off with the aminosalicylates. That's always going to be kind of your first round of agents you're going to go with, okay? If that is not going to be effective, or if they have more moderate to severe disease, that's where you want to consider adding on stuff like your corticosteroids, right? Especially if they're having like an acute flare-up. If you can utilize topical corticosteroids like topical hydrocortisone or something, so you can, for instance, try to see where that comes up here, or like something like budesonide is going to be good from an oral standpoint because again, it has very limited systemic absorption. That would be the next thing you want to add on. So start out with the aminosalicylates, add on corticosteroids as appropriate, and see if you can get them back under control, back into remission, right? If that is not working, then that's where you want to start to consider adding on things like immunosuppressants. Again, we're getting into the drugs. We're starting simple, going with things with less systemic side effects, working our way up to things that are more immunosuppressive. They're going to have more side effects associated with them, but may be more effective, right? So think about things like mercaptopurine or azathioprine. Notice when we get into things like infliximab, there's going to be a lot of mAbs that are out there. And again, it's a really kind of a big cash industry right now. So if I didn't mention it specifically in this section, I'm not going to ask a question about it. So it's like certolizumab. Again, we could do a whole class just on monoclonal antibodies that are out there. I'm not going to do that. I'm going to keep it focused on the main ones that we run into from a clinical standpoint. And again, even more severe than that is where you start to consider things like cyclosporin. Again, you're just adding on more and more agents. So you may have someone who's on methotrexate plus infliximab, for instance, in order to help kind of keep that under control there, right? The main goal, though, is once they're under control, scale back their therapy. You always want to try to get them off the most deleterious medications, the most side effect prone ones first, and then scale them back. So in most of the time, it's going to be the corticosteroids. If you can try to wean them down off the corticosteroids or as to a lower dose as possible, that's going to be preferential, okay? Someone was saying, for the maintenance dose of Humira, would you recommend starting with every other week, then increasing to weekly if needed, or is it dependent on the severity of the patient? That'll be very dependent on the patient, depending on severity, what kind of side effects you're getting from the drug, what the insurance is going to cover, what the provider thinks, so that'll be very dependent. Obviously, less often you can administer it, the better, because that helps out with compliance, I think. So that's always going to be preferential. Okay. So with Crohn's disease, very similar goals that are going to be seen here. And again, dependent on where the severity and location of disease is, will dictate what drugs we're going to use. Notice here, we're going to just start out with oral therapy. We're not going to mess around with doing any of the rectal stuff because, again, this is more diffuse disease throughout the entire GI tract. Note here that we're going to be starting off with our same sort of drugs. The aminosalicylates are going to be used first. Remember, you may have some role to play with antibiotics with Crohn's disease. That's not really going to be a thing, be playing a role with ulcerative colitis. That's one little bit of a difference there. And remember, what do you add on next? Corticosteroids are typically going to be added on, especially if they're having an acute exacerbation. And then if that's still not working, if they're still having issues, that's where we want to consider utilizing our immunosuppressant drugs, either monoclonal antibodies. We can do things like 6-mercaptopurine, azathioprine, things like that. And then eventually they may work all the way up to cyclosporin, but hopefully if you can keep them from that point, that's going to be beneficial. Again, try to get them off the steroids if possible. That's usually going to lead to the most of the kind of chronic side effects you'll see with that stuff. So it's usually what I would say to do. Again, so if I'm saying, hey, they're already on prednisone 20 milligrams a day, they're getting sulfasalazine, what would you want to add on next? And I could put another corticosteroid on there. You say that's not good. I would add, say a rectally administered drug, and you say, well, that's not going to work for Crohn's disease. Or I could do like infliximab. Yeah, that sounds like a good, reasonable next drug to continue at that point there. So those are kind of the questions I'm going to be asking when looking at these sort of questions. If that makes sense. Again, once I get into maintenance, that's where you want to try to scale back therapy as much as you can, especially with the immunosuppressants, especially the steroids there. Again, keep in mind the methotrexate and the antibiotics are more frequently used for Crohn's disease. That's just what they see more often. Especially the methotrexate just tends to be used more for Crohn's and ulcerative colitis, but may depend on the provider there. And again, corticosteroids have no role in the maintenance therapy, so you always want to get them off of the corticosteroids if possible. Otherwise, you may not have their other meds sort of optimally dosed at that point there. Okay, and again, most people are going to be on this lifelong, but you may find some people with more really mild disease may not require lifelong therapy. Just depends. Okay. So getting into the irritable bowel syndrome here, this is going to be a fairly quick section talking about basically these patients that have issues with changing of their stool frequency or consistency based off of, sometimes you'll find IBS with diarrhea, sometimes with constipation. This depends on the patient. Sometimes it'll be a little bit mixed. And you tend to see it a little bit more often in women than men, as it turns out. So a lot of times we don't really know what's going on here. Some of it could be a sort of a sensory motor issue. Some of it could be some dysregulation with 5-HT receptors. If you recall, 5-HT is serotonin. Psychological factors factor into this quite a bit. I see a lot of cases of stress-induced cases of diarrhea or constipation there. And some people may feel it even has to do with bacteria that is overgrown in some cases. But ultimately, we may not really know overall. But how we classify is mainly going to be either IBS with constipation, diarrhea, there's mixed, or there could be sort of a unsubtyped IBS. I'm mainly going to focus on looking at the IBS C and D because that's where the main therapy will differ between the two, which makes a sense, right? For these patients here, quality of life is a big thing. If we can try to limit how many episodes they're having, and again, trying to understand like why are they having IBS in the first place? Is it stress? Is it something we can deal with from a psychological standpoint? That may be kind of the most beneficial thing they can have, as opposed to introducing new medications, right? So patient education, look at their diet, look to see what kind of triggers they have, whether it be certain types of food, etc. Even with psychotherapy, obviously CBT is going to be hugely beneficial for them in a lot of cases, but even things like hypnotherapy have been used before. I've been hypnotizing you this whole time, you don't even realize it. I've convinced you that you're actually into pharm. You love this topic so much. Kidding. So the therapy for these should look pretty similar to what we were seeing with the individual cases of constipation or diarrhea specifically. But we'll get into more of these, and there's a few new drugs we'll look at as well here in just a little bit. So you can kind of refer back to this, and we'll talk about these individually. As we mentioned, for bulk forming laxatives, this could be good for either IBS with constipation or diarrhea, and it makes may sound a little counterintuitive, but it makes sense because if you have someone who is having constipation, this serves as a bulk forming laxative. It can help draw more water in, can stimulate elimination of the feces, right? If they're having diarrhea, this actually can help out too because it can absorb some of the excess water from the colon and can help stabilize things a little bit. So it can even help reduce diarrhea in some of these patients, even though we mostly think about using these for constipation. So kind of the benefit of either or, which is nice, and should probably be recommended for both cases. This can include things like your psyllium husk, your methylcellulose, etc. Again, I'm not going to ask you specifically on dosing or anything like that, but recall that patients are not going to like these drugs in a lot of cases. They're very gritty. They have a bad texture to it. It may not taste very good. So, compliance is going to be a challenge with a lot of these. Okay. In terms of osmotic laxatives, these are going to be better for patients with constipation. So your things like mag hydroxide, your polyethylene glycol, things like that are going to be used for more on the constipation side of things. The bulk forming laxatives can be used for either constipation, diarrhea. Osmotics are going to be used for the constipation, which makes sense based on what we talked about before. Now, what's interesting here is sort of a unique set of drugs here. For instance, we have the chloride channel activators. So this is actually a drug that is a derivative of prostaglandin E1 that actually will increase intestinal secretion by activating these chloride channels. So you activate these chloride channels, you get more intestinal secretions. Could be good for patients with constipation, right? Because more fluid flowing in means more stretch, more signal to have a bowel movement, right? So we have one drug here called lubiprostone or amitiza, and you're going to find here that this one's beneficial because it doesn't really have any systemic absorption, and so like nausea is the most common adverse effect, so really very well tolerated, but could be used as an add-on if patients were not managed well enough with just laxatives by themselves. We can also utilize our tricyclic antidepressants, and we're going to talk about these at length when we get into the behavioral health section later on. I may have already started talking about these with Dr. Austin, perhaps. But the TCAs are kind of an older school set of antidepressants, and they work by preventing the reuptake of things like serotonin and norepinephrine. And so what you looked at before, the pathophys, maybe there's some dysregulation with serotonin going on. And so it's thought that these may be able to help from that standpoint. Also remember, if patients are anxious or, and that's what's triggering some of their IBS, then that's where these can also help out with that, because these are frequently used to treat anxiety as well. Okay. So it makes a sense. Keep in mind, these drugs do not kick in very fast. They take usually 3 to 4 weeks before you really start to see full effects for that. And so you can see either like something like disipramine, our newer SSRIs may be a good option for IBS with constipation. But more common ones include things like amitriptyline, imipramine. Just know that you can use these for irritable bowel syndrome. I'm going to talk about these much more in detail later on, so I'm going to get into details on that in like upcoming sections when we hit behavioral health. So here's a couple interesting ones that affect serotonin specifically. So this is a 5-HT4 partial agonist, and the idea is by partially agonizing this receptor, you're going to stimulate the peristaltic reflex, right? And so these are really kind of interesting because they are not used very frequently because of some of the side effects you can run into. And so we have one here called tegaserot or Zelnorm, and this one here is found that it's only for IBS with constipation in women. They actually found that men had no benefit from the drug, worked just like placebo did. So kind of wild that there's a female-only medication, even though presumably men have the same 5-HT4 receptors there. So interesting point. However, you don't want to use this unless patients are really refractory to other therapies, because of the fact that there's been issues with, especially with post-marketing, of causing ischemic colitis and serious cases of diarrhea, which makes sense because it stimulates peristalsis. And so in fact, here there's actually an increase in risk for cardiovascular events as well, including death. And so this is something to where it's really restricted. In fact, if you want to use this, you'd actually even have to get what we call an investigator new drug protocols, of a special form you'd have to sign up with the provider in order to make sure they could even get the drug, kind of like a REMS program like we've talked about previously with like isotretinoin and things like that. So really rarely used drug, but could be beneficial for someone who have been refractory to everything else, right? We talked about the antidiarrheals, loperamide, working on the opioid receptors. One we haven't talked about recently is cholestyramine. If you recall, this is actually a bile acid sequestrant that was used back for hyperlipidemia, if you recall back in the day. This could be good for patients who maybe don't get any benefit from an opioid like loperamide, or if they're having diarrhea after getting a cholecystectomy. So if they don't have their gallbladder anymore and they're kind of just leaching all these bile acids into the GI tract, this helps to bind those up and may help out with some of the diarrhea they're getting from that. So that's one option for those patients. Really, any of the bile acid sequestrants could be used. I just see cholestyramine being used most frequently. Next, you have your 5-HT3 receptor antagonist. So this would actually be used for someone who has diarrhea with IBS, and this is actually also limited to women as well. This is allosetron or Lotrinex. So you do a 5-HT4 partial agonist with IBS with constipation. Here we're doing a 5-HT3 receptor antagonist for IBS with diarrhea. And this is actually also going to be really limited in who you're going to use it for because of its risk for causing things like ischemic colitis, severe constipation, and increased risk of death. But again, if they're refractory to everything else, then this could be something you could potentially use. And there's some cases for antispasmodic agents. This would include things like hyoscyamine and things like that. Keep in mind, a lot of those are anticholinergic, so they're going to have a host of side effects like we've seen before. They can cause constipation, urinary retention, all of that. So you would want to be careful with that and use more on a sparing, sort of as needed sort of basis there, because you can run into some issues where you have some tachyphylaxis with prolonged use, but just use it sparingly. You should be okay from that standpoint. Okay. So different options here. So hyoscyamine is one we mentioned before, but there's a few others you can run into. So things like dicyclamine is used somewhat frequently, glycopyrrolate. Some of these we will talk about more when we get into urinary incontinence. We get into urology later on. You'll see them used as well. So there's a lot of crossover here with antispasmodics and things used for urinary incontinence, as we'll see, because they're both utilizing the anticholinergic properties there. Really, the big ones I would want you to remember are going to be hyoscyamine, dicyclamine, and glycopyrrolate, just because these get used most frequently clinically. Some of these are more old school drugs that you don't see used all that often. So, for instance, like hyoscyamine, scopolamine, atropine, and phenobarbital is like Donatol. Like I've seen it maybe once or twice, and I'm pretty old at this point. So this is like really old school kind of stuff, but you may see it used occasionally. So these are three of the main ones I would probably focus on: glycopyrrolate, dicyclamine, and hyoscyamine. Okay. And then for some patients, they have irritable bowel syndrome related to bacterial overgrowth. And this is where we can use a drug called rifaximin. This is actually going to be pretty similar to the category of drugs like rifampin. However, this does not get systemically absorbed. So it's good because it doesn't cause any systemic problems here and can be beneficial if they have like small intestinal bowel overgrowth. The SIBO can be used there occasionally. And so looking at this, you can kind of see the algorithm for how you'd want to go about treating these patients here. So is it more constipation? Is it more diarrhea? Obviously, education, bulk forming laxatives are going to be recommended for both. And then you want to consider then, if they're having more diarrhea, using things like loperamide. If they're having more constipation, consider things like using more osmotic laxatives. And then if they're really still staying refractory to everything, that's where you can consider using something like tegaserod or losatron. Keep in mind this would only be for female patients, as men just do not respond favorably at all to these drugs there. And again, these would be really rare because of all the bad side effects they could cause. Obviously, focus on other stuff like stress reduction, CBT, things like that, right? Okay, so that's it for the GI section. Do you guys have any questions on that? I have a few minutes left. I would like to begin the next section if you don't mind. I know what you're thinking. You're thinking, oh man, I don't want to do that. Which I say, we got a lot of stuff to cover, so I'll make sure I'm using your time effectively. Okay, so up next we have our neurology and headache disorders. And so I at least wanted to cover the beginning here because I think it's important to lay the groundwork. So that way when we get into our next talk, which I think is probably tomorrow, we can kind of hit the ground running with our drugs and what. Double check. Yep, we meet tomorrow after interviews. So anyway, so starting off with our talk on epilepsy here. What is epilepsy? Well, Webster's dictionary defines. I'm just kidding. So basically, what we're seeing here is that there's normally a balance between stimulatory signals to have action potentials in the CNS, and there's inhibitory signals. When you have a seizure, you're having either less of the inhibitory signals, or you're having more of the stimulatory signals, or maybe a little bit of both. And so overall, you're having this sort of like dysfunctional, disorganized pattern of neuronal activity leading to seizures, right? There's various types that are out there. We're going to find that for the most part, our medications are fairly broad spectrum, meaning they treat a wide variety of different types of epilepsy. And we'll see that, oftentimes I'm not going to necessarily be trying to differentiate between a generalized versus localized, case a seizure, or I'm not going to really get into the difference between various subtypes of seizures. There's one example that I'll get into in a little bit, but in general, a seizure is a seizure, and for the most part, the drugs are going to be working for most of them. So that's why I'm not going to make a lot of delineations here amongst the different seizure subtypes, although you may get that in CMS, and you may be responsible for knowing that there. Anyway, there's also what we call status epilepticus, and so this is where you'll see this more so like in the ER, perhaps in the ICU. And this is basically where patients have continuous seizure activity, or perhaps their seizure will break, and they'll be in that post-ictal state. If you're not familiar with the post-ictal state, it's kind of that state where they're still having a depressed mental status. They're not actively seizing, but they're not really back to their baseline mental status yet. If they're in that post-ictal phase and then they go right back into another seizure, that's considered status epilepticus, right? And so that's a really big emergency because we worry about having cerebral ischemia. They can aspirate stuff into the lungs. I mean, all kinds of problems they can run into. So I'll talk about status epilepticus more specifically a little bit later on there. So why do people have seizures? Well, there's a lot of different reasons that are out there. So things like, certainly head trauma. You can have emotional stress can affect this. Even hormonal changes. You can find sometimes patients, especially like female patients, when they are placed on oral contraceptives that are estrogen and progestin based, they can actually have changes in their seizure activity potentially. In terms of medications, a lot of different things can cause seizures. I could show you a whole mnemonic that we use to list out our differential for drugs that cause seizures called Otis Campbell, but I want to get into that today. But you can see here things like theophylline, which we recall talking about that with COPD. Alcohol is kind of interesting because if you recall back when in March when we went on lockdown, they talked about essential businesses. A lot of people thought it was really funny that, liquor stores and whatnot were considered to be essential businesses. And they're like, oh, that's so funny. People got to have their alcohol because we're all depressed as we're in isolation. But really, they are providing a medical necessity for some of these patients that are really dependent on alcohol. I could probably wax poetic for an hour or two about the effects of alcohol and all of that. But basically, alcohol is a depressant, right? It suppresses the CNS. And so normally it works, if anything, as an anti-epileptic product, right? But it's those people who become dependent on it that when they withdraw from alcohol, that's where they can have seizures, right? Have you ever heard of like the DTs or delirium tremens? That's a very severe form of alcohol withdrawal that frequently manifests as seizures. So having access to that alcohol could be life-saving for some people, right? Because they're so physiologically dependent on it. But a lot of drugs can do this as well, like some of our antipsychotic drugs we'll get into later, antidepressants. And then what's interesting too, I think it's interesting, but just like with our antiarrhythmics, how any of your antiarrhythmic drugs could cause arrhythmia, same thing here. Any of your anti-epileptic drugs, as AED, anti-epileptic drugs that treat seizures can actually cause seizures. Okay, so a big thing to consider there. And then non-compliance with AEDs is also quite frequently the case for their seizures as well. We would have a lot of times kids would, being at Nemours, we have a lot of kids coming in from Disney. If they're coming in with seizures, oftentimes because they're traveling and maybe they forgot their meds or they didn't take it that day. And so having low levels of AEDs frequently can be the cause for these seizures here. And again, you want to find out as a provider, is this something new happening here? Is it because they're not taking their meds like they're supposed to, or maybe they're getting way too much of their meds, as the case may be? Paige said, we had some alcohol withdrawal patients that had such bad mental status and seizures. They went sent to the ICU, and under the orders, medications are given alcohol. I want to say every 6 to 8 hours. Yeah, we used to do that. You used to see orders for like, one beer PO QHS or something like that for some patients that had, they were being admitted, but they didn't want to cut them off cold turkey from their alcohol. We don't do that so much anymore. Like and again, the pharmacy is where we actually kept that. So you'd have some pharmacies that had, a couple 6-packs, and the course is always like the worst beer possible is like, basically they'd get like, actually, I don't want to say any specific beers. I don't want to offend anyone. Have that on my evals. He disliked the beer that I like, but regardless, we stopped doing that because nowadays we actually switched over. Yeah, Shelby's gonna put alcohol in their peg tubes. Yeah, absolutely. Nowadays we've actually switched over to using a different class of drugs, which we're actually going to get into much more in depth here. They're called benzodiazepines because they really do similar things as alcohol. So it may not be quite the same effect as alcohol for these patients who are really dependent on it, but it'll kind of get the job done. So we'll talk more about that a little bit later on. I was saying, what would you do if you had drug withdrawal for a patient on an illegal drug? That depends. Most of the time, the withdrawal may be different depending on the type of drug you're dealing with. So cocaine withdrawal looks very different than someone who's having like a benzodiazepine withdrawal or an alcohol withdrawal because physiologically they do completely different things. So, but usually if they're having a withdrawal that's causing them to be quite anxious, or if like an instance like opioid withdrawals, they get very grumpy is putting it lightly, but they get very very anxious and may try to fight staff and things like that. That's where usually our benzodiazepines are going to be like kind of our drug of choice for the most part. But I'll talk more about those a little bit later on. But our benzos are definitely our friends in a lot of those cases of significant withdrawal. So anyway, so getting back into seizures, again, this is an abnormal pattern of neuronal action potential is occurring here, right? And so again, usually there's this kind of hyperexcitability, the hypersynchronization that happens here. And ultimately what we're having is this disbalance here between the two neurotransmitters primarily. And so again, this is the semester of neurotransmitters. We're going to talk about these all. So I've already alluded to serotonin, but now here's two other ones now. So there's two main ones here. There's GABA and there's glutamate. And interestingly enough, glutamate is a precursor to GABA. It's important to have a balance here. GABA is the major inhibitory neurotransmitter. GABA is putting your foot on the brake of your car. It's going to slow you down and stop that hyperexcitability, okay? GABA is good for slowing things down. Glutamate is the gas pedal on your car, okay? So glutamate is excitatory. It's going to stimulate neuronal activity, okay? If you have too much glutamate, you're going to have a seizure. If you don't have enough GABA, you're going to have a seizure, right? So it's important to keep a balance between these two here in order to kind of keep things in check and kind of working normally. So if you recall a lot of the talk about action potentials and stuff we talked about back in, say, for instance, like either like in your physiology class you had with Professor Kaplan, or if you recall, we talked about the cardiac action potential. A lot of the similar things is happening here, right? A lot of the same concepts. So it's, if you remember that, it's going to help you here. So if you recall, all neurons are going to have a resting membrane potential, right? Usually like negative, I think negative 70 millivolts or something like that. And if you change that resting membrane potential, you can find that the risk for having a action potential is higher or lower, right? So if I make the cell more positive, I go from negative 70 millivolts to negative 50, I make it more likely for that cell to have an action potential. And so it's really important that we maintain that resting membrane potential at a normal level to prevent hyperexcitability from occurring, which can lead to a seizure. And so this is where our sodium potassium pump comes into play here. So sodium potassium pump, very, very important to pump sodium out of the cell against the concentration gradient, pump potassium into the cell against its concentration gradient, and utilizes ATP to do that. Sodium potassium ATPase pump. This is the same pump we saw on the heart, keeping its resting membrane potential normal. This is the same pump, right? And so you may find that if this pump is not working effectively, you can actually, what we say, we lower the action potential threshold, meaning that the cell's negative potential is actually getting more positive, meaning it's more likely that they're going to have that action potential fire inappropriately and thus have trigger off a seizure, basically. Now, keep in mind, there's still going to be a refractory period here between action potentials. And in some patients with epilepsy, they may actually have lost that. So the refractory period may be shortened or absent completely. And that's why they can have these really repetitive action potentials occurring here, leading to their seizures, right? So, of course, with diagnosis, it's always important to get a good history. You want to figure out what any kind of preceding events that occurred was, figure out what medications they're taking or not taking as the case may be, and certainly can get into things like looking at certain toxicology screens, right? If you were to get into, doing more invasive diagnostics like EEGs, MRIs, things like all of that can be very beneficial as well, especially if there's like any kind of like organic cause, like a tumor or something like that is actually causing the disease say itself. Keep in mind, it can be really difficult, especially with illicit substances, to determine if they're present or not, just with routine toxicology screens. So don't always take that to be, the gospel truth. If you get someone who gets a urine drug screen and comes back negative, you can't rule out all drug exposures. A lot of things they just don't test for, unfortunately. Wait, someone's saying, someone says, so what would be best for a 45-year-old patient? Actually, I'm going to come back to that. I'll come back to that in just a moment. I don't want to get too off track here. Okay, so, and again, actually, I put the Otis Campbell mnemonic on here. I forgot I did that. So there's a lot of reasons why you could have a toxin-induced seizure. Keep in mind, I'm not going to ask you this entire list here, but just be aware that there's a lot of things you want to consider on your differential for someone who just shows up with a seizure, especially if it's new onset, especially like an adult. Like, it's kind of rare for adults just to kind of develop seizures out of nowhere, unless there's something going on, like either a drug exposure, tumor, something like that. But just be aware there's a lot of different things here. I'm not going to go over every single one of these because I just don't really have time, unfortunately. If you have specific questions, certainly I don't mind talking about that. But big ones you're going to run into is going to be withdrawal from sedative agents like ethanol, so alcohol withdrawal. Benzodiazepine withdrawal is going to be a huge one. You're going to find, especially with like patients who are on medications to treat things like psychological disorders, things like lithium for bipolar disorder can be another big thing as well. So we'll get into more specifics as we go on, but even things you may not think about, like carbon monoxide exposure could lead to a seizure, right? So someone had been in a house fire or maybe they're trying to commit suicide and they put they were running their car in the garage or something like that. Could be a source for some of these seizures. So it's quite a variety of things that can lead to this. Now, we're dealing with these patients. Mainly, what we'd like them to do is to get down to no seizures whatsoever. For a lot of these patients, though, that's not going to be a possibility. For some patients, they may have, a dozen seizures a day. And if you can just get them down to maybe like 2 or 3, that could be considered a major victory. And so that's the ideal thing, but it may not always be achievable. A lot of the drugs we're going to talk about have a lot of side effects. So if we can try to mitigate those, that'll be beneficial. And then try to address any other issues the patient's having. And remember, improved quality of life is another big thing as well. So trying to make sure that, what are the patient's goals? Do they want to go to school and get a degree, for instance? Like, it may be difficult to do that if their seizures are not under control, for instance, right? So different things you want to consider and maybe individualized for that particular patient. But something to consider are going to be things like the pharmacokinetics of the drugs we're dealing with. So for instance, like with phenytoin, which is a pretty common anti-epileptic drug, we'll get into more detail next time, the dosing range can change wildly depending on the age of the patient, right? Because their ability to metabolize it changes as well. So this is why you always want to make sure, especially with kids, to go back through, see how their weight's changing, see how their age has changed, to make sure that you're dosing everything as appropriately as you can, because you may have a kid who develops a seizure disorder, and it's because no one ever went back and accounted for his increase in weight, that now what was appropriate for him when he weighed 20 kilograms is not appropriate when he now weighs 25 kilograms, for instance, right? Or he's maybe aged up and is metabolizing things differently. Look at things like their ability to comply with the medical regimen. If they're taking 4 or 5 different medications a day, that may be very difficult. And then things like insurance coverage can also be playing a big role as well. Okay. And then when you're evaluating these patients, one, you want to make sure, do they actually have a seizure? Could it be something else that's happening there? We always like dealing with pseudo seizures in the ER setting. So find this more on the adult side of things. We'd have patients who would have a quote unquote seizure, and then they'd be in a post-ictal state, laying in bed. And so we would do the hand test to see if they actually had a seizure or not. And basically they're laying back on the stretcher, and you'd raise their arm over their head, and then you just let their arm go. And if they move their hand out of the way and to avoid hitting their face, then you had a decent idea that they may have been fibbing a bit. But figure out, did an actual seizure occur or not, and then figure out, okay, well, is this like a one-time thing, right? Or is it going to be more of a prolonged issue? For instance, with febrile seizures, you don't treat febrile seizures with anti-epileptic drugs because the issue is the fever. So you treat the fever. Once the fever's gone, no more seizures, right? Versus something that's going to be more so of a chronic issue. That's where we want to start to consider, okay, well, do we need to actually treat these patients chronically as well with pharmacotherapy? And then we'll look at some things like monitoring parameters and trying to decide what makes a drug most appropriate for a given type of patient, right? So, and we're going to find that there's a lot of options that are there. Most patients will do well with monotherapy with anti-epileptic drugs. Some patients may require dual or more therapy, as we'll see. And then there's other things you can do as well. So we'll talk about things like, or I'll allude to things like vagal nerve stimulators, surgery, where you can actually remove portions of the brain that actually are causing the seizures to occur in the first place. And then even things like ketogenic diets are another way we can try to help make it more difficult for patients to have seizures. And I'll probably leave it on there and talk more about that later, because I want to kind of mention that more specifically. I think it's really neat, and it's important from a drug standpoint, how to maintain that ketogenic diet. So I think we'll cut it off there. We'll come back and get into more of the drugs and all of that tomorrow. And so someone did have a question on the board here. They said, so what would be best for a 45-year-old who needs Humira for his RA, and that is all you know about the patient, weekly or biweekly? Well, let's look it up, right? When in doubt, look it up. Bring up my LexiComp. If you guys want to hop off, you are welcome to. If you want to stick around, I am fine with that too. All right, so let's say, what was the drug they asked about? They said Humira. You guys are asking about the prescription assignment, I imagine, but that's okay. But again, when you're looking this stuff up, it's good to look at, okay, what's the normal dosing, kind of where you can, what's your starter dose, what you would increase it to, etc. All right, so let's say, for instance, we're doing something like Crohn's disease, for instance. You can see here, okay, may continue aminosalicylates or corticosteroids if necessary. Azathioprine or mercaptopurine may also be continued. Again, kind of talking about, okay, how can you use these drugs together? Sometimes you don't want to use too many immunosuppressants at the same time, because it could have risk for things like, secondary infections and whatnot. So notice here, so okay, 40 milligrams every other week beginning on day 29. Some patients may require 40 milligrams every week as maintenance therapy. So that's one of those things where you're looking at, you say, okay, well, let's assume my patient is going to act like a typical Crohn's disease patient. Maybe I can start off with every other week and then see how it goes, right? So again, this is part of the reason why I do these assignments, to try to get you guys thinking about, well, what would I do if I was really in this situation? Chances are, just start off with whatever is kind of the most basic, because chances are your patient will act like a typical patient, right? So don't always, everyone kind of reverts back to the mean in general. So see how they respond, and if they don't respond well enough, then you can bump it up and go every week potentially, right? So that's how I would kind of tackle something like that if the question came up for like an assignment or something, or if some providers ask me, hey, what would you do? That's kind of the same advice I would give them as well. All right. Any other questions you guys have? If not, we'll get into our neuro stuff tomorrow in more depth, and hopefully you guys had a nice whetting of your appetite, and it'll be ready to go for tomorrow. Yeah, thank you. Thank you all for joining me, and I will see you all then. See any questions? I'm going to end the stream. I will see you tomorrow.